That's so. At the presidential imbizo yesterday, President Cyril Ramaphosa affirmed that the number of COVID-19 infections will continue to rise as more sectors of the economy open up. Health Minister Dr. Zweli Mkhize says South Africa's health system has been put to the test, with 10,700 people admitted to 269 health facilities across the country. South Africa does not have enough ICU and healthcare beds or ventilators, and our public health sector is taking a beating. That's according to Professor Rudo Mathivha, who's head of ICU at Chris Hani Baragwanath Hospital. The Prof joins us now via Zoom for a bit more on this. Prof, thanks very much for your time and welcome to the AM report. So in some instances, we've seen the health minister being quoted as saying that he's concerned that the weaknesses of our system are starting to show. How far from the brink do you think we are? Prof, are you able to hear us? All right, it doesn't appear that our connection to Professor Rudo is well established there, so we'll try to get those gremlins sorted out. It's certainly a story worth keeping a close eye on, considering, of course, that we're all so closely affected by the COVID-19 pandemic. But the predictions were always there, weren't they? I mean, this was the rock bed of the motivation behind introducing a lockdown to begin with, and a hard lockdown at that. Speaking of which, we're also hearing that Gauteng might in fact find itself returning to that place, considering the surge in new daily infections. And those are, of course, going to have some type of bearing at hospitals like the Chris Hani Baragwanath Hospital, for which the Prof is working there. So my understanding is that the Prof is joining us now once again. Prof, we're just going to test the line to you very quickly to check if you can hear us. And if so, my question was, how far from the brink of collapse do you think our health system is?
Good morning. It is very difficult to predict exactly when the systems will break, but we are filling up and the bed shortages are starting to be apparent, especially in terms of ICU beds and high care beds, because the numbers of patients presenting at hospitals have really shot up exponentially. We are starting to see the sicker patient spectrum presenting at the hospitals. So our healthcare facilities, both in private and in the public sector, are starting to take strain. And if we continue along this trajectory, we will see the scenarios that played out in the European countries and in New York in particular play out here. But we can actually prevent that as a society by using non-pharmaceutical measures of interrupting the spread of the virus. So the measures of social distancing, wearing masks and hand washing, and not having to go out unless you don't necessarily have to, will actually help markedly. And those with chronic conditions, by staying on their medications or not defaulting, particularly diabetics and those with hypertension, if they can control their conditions, that will make them not present in very severe disease, because those are the two comorbidities that we have identified as carrying a very poor prognosis when they get this viral infection.
Right, and staying on the issues around comorbidities, are you also witnessing what many people have spoken about, which is those with those underlying symptoms not coming forward to actually get their treatment so that they are actually in a position where they're able to stave off, the adverse effects of COVID-19, so to speak?
So what a lot of healthcare facilities have done from a while ago, even when we went into the first high-level lockdown, was to make sure that a lot of patients got enough medication to last them a while so that they wouldn't run out of medication. But even now, primary healthcare clinics are continuing to dispense chronic medication. So people should still go to their primary healthcare clinics to get their chronic meds and continue being on those. So that's particularly diabetes, hypertension, and HIV. Those are our 3 high-risk chronic conditions. So this is not the time to actually default on those treatments. So go get your medication, continue taking those medications, keep tight control of those chronic conditions, and we should actually be able to control your viral infection when it happens.
Right. You speak about medication, Prof. We'd heard a lot about dexamethasone over the past few weeks. For many people, it was the first time they were hearing of it, but my understanding is that, particularly in South Africa, we've been using this form of medication for quite some time. Part of its effects, we're told, is to try help those who are critically ill patients, those who typically would be in ICU. From what you're reading on the ground, is this drug working?
So dexamethasone is a drug that has, it's an old drug. It's a steroid. And it so happens that in South Africa, in my ICU and in Professor Guy Richards' ICU, who's at Charlotte Maxeke Hospital, we had already written it into our protocols for COVID ICU patients to be the steroid of choice to use as an anti-inflammatory agent. It wasn't because we could see into the future, but it is easy to administer. It has got a longer action of duration, and it has good anti-inflammatory properties. So we were already using it. So when the study was released from the UK, for us it wasn't like a major aha moment, because we had actually already started seeing the effects in our patients. But it's not just dexamethasone on its own. It is dexamethasone in conjunction with good supportive therapy of an ill patient. When a critically ill patient comes in, you have to step in very quickly and support them, give them supplemental oxygen, and give them high flow nasal oxygen, support their respiratory system very quickly, so that you try and interrupt them progressing to getting on a mechanical ventilator. So in South Africa, we had actually drawn up protocols that we have been sharing between the public and the private sector on how to manage these patients. And in fact, we have been successful in interrupting a lot of patients advancing to being mechanically ventilated. And we use proning patients. So we lie patients on their tummies. We support them under their shoulders and under their hips. And we give them high concentrations of oxygen. We give them chest physio. We give them intravenous fluids if they need. We tightly control their diabetes. We tightly control their hypertension. We give them the dexamethasone. We give them immunoglobulins. We give them certain antibiotics. And we tightly monitor them so as they get better quicker, so they don't advance to the next, they don't deteriorate to the next level where you have to intubate them and mechanically ventilate them.
Right.
And if you do that, you interrupt progression of the disease to the next level. And that is how we have been treating patients here in South Africa. However, having said that, I'm not saying there are patients that won't go on to mechanical ventilation. There are those patients that will still progress. There are those patients that will present a little bit late, that are too far gone, that you may have to put on the mechanical ventilator. And those are the difficult patients. Those are the patients that may stay long in the ICU. Some of those patients may actually not recover, and you get a mortality rate in those patients.
Right. We're going to have to leave it there, Prof. Thanks very much for your time and for getting us into the picture. Certainly is a complex and convoluted process, one which we'll continue to visit here on the AM Report.